So just by brief way of introduction, I think most people in the room already know Dr. Chris Bundy. I don't know about the folks who are joining us online. He is the medical director for the Washington Physicians Health Program. He comes annually to give a presentation to the commission, including commission members and staff, on kind of where WPHP is at. Their annual report to the department, which is the contracting agency, is included in the meeting materials. And I commend it to anybody if you want an overview of all the work that WPHP does. I asked him to additionally cover a handful of other topics this time for the benefit of the commission members and staff. So without further ado, we're going to get Chris up here and get this started. Any questions before we do that? Nope. Awesome. Chris.
Hey. Wonderful. Can you all hear me okay? Well, good afternoon. I'm Chris Bundy, as mentioned, Executive Medical Director of the Washington Physicians Health Program this year. This is my 10th year with the organization. Prior to that, I was the Chief of Mental Health at VA Puget Sound Healthcare System. I'm a psychiatrist by training. I'm boarded in adult and geriatric psychiatry and addiction medicine. As Kyle mentioned, I try to come by annually to talk with you all a little bit about our program, but also to hopefully entertain and delight with other topics of interest that aren't just simply a reporting of how our program is doing for you all. I enjoy this meeting a lot. I enjoy the work that I do with the commission. I work actually a lot with the investigative staff, with the staff attorneys, legal policy, communications. We have really a robust and mature relationship. And I think in many ways, if you ever make it to an FSMB meeting, you will see that Washington and WPHP have an enviable physician health program regulator relationship that is not always the case in every state and should not be taken for granted. And it was really people before me that helped build that relationship. If you really want to know what the history was like and how the board viewed WPHP back in the early 90s, I invite you to have a conversation with Mike Farrell because he lived that world and that transition. So it wasn't always this way. So I think that this time of year when I come and talk to you all is the kind of time when I am also reveling a little bit in gratitude and appreciation for what we do have because it does really work well. I was just at the Federation of State Medical Boards work group on reentry on Monday as a Federation representative. I am the Chief Medical Officer for the Federation of State Physician Health Programs, which represents the 50 states in the United States that have PHPs and providing testimony. And part of that testimony, of course, is informed about the wonderful opportunities I have to work on issues of reentry with the regulator when the regulator is involved in that. We certainly work on return to work and reentry all the time in cases that the regulator isn't involved with, and I'll show you some data. Shows you what proportion of the folks that we work with are not, that are never known to you. But there are also cases of overlap where you have concerns about reentry. We had a couple of those cases this morning in our appearances. And again, just another example of those great opportunities that we have to work together collaboratively. We just had oh, I got to use that. Okay.
Maybe.
Okay. We just refreshed our mission and vision this year. Board just approved these. We also refreshed our values. And I'm excited to say that our mission now reflects, I think, a trust that we've earned across the healthcare ecosystem in Washington, not only with you all, but with the employers and healthcare organizations that rely on us to provide evaluation and intervention, assessment, and treatment, and then health support and ongoing monitoring when individuals are struggling with conditions that can affect their ability to safely practice when illness is showing up at work in one way or another in the healthcare system. We provide confidential support, we measure our outcomes, and we wanted our mission statement to really lean on the reassurance that we provide. I tell my staff every day we provide lower blood pressure for people who are out there worried about a friend, family member, colleague, employee, peer, that they can actually get help without being in trouble, and that help without being in trouble encourages people to get help earlier before the wheels have come off. And then, of course, in today's world, we're really worried about physician shortage over time and practice sustainability and workforce sustainability. So every good doctor that we have invested heavily in as a society to provide care in our communities is needed. And to the extent that we can restore and continue people in practice who are good doctors who have the unfortunate problem of becoming ill, the better off for us all. And really, our vision is simple: to advance the health and well-being of our medical community. Let's deputize you all for a moment and give you a day in the life of a WPHP clinical coordinator. Invite you into one of our clinical staffing meetings on a Tuesday morning so that you can think through a case with us as we might see it. And our first case is Dr. Collins, referred to WPHP for recurrent failure to follow administrative procedures, charting delinquencies, seeing patients in clinic after hours, and accessing the record of a patient that was not under their care. So the employer calls us, they have some concerns about this individual based on these observations. And they say, what else might be going on with this individual? Why this behavior? This is not unusual. We have referrals for the quote unquote disruptive position or problematic workplace behavior, psychiatric, substance use, all manner of things, but practice impact essentially. On initial assessment, which is usually an hour and a half to 2 hour evaluation that's preceded by a health questionnaire, a Montreal cognitive assessment, a suicide risk screening, and toxicology testing. What we find is self-report of some cannabis use. This individual reported that they really, they accessed a patient's chart that wasn't their patient, but they were just looking up some lab values for their boyfriend that their boyfriend wanted. And so they, were just checking on those and reporting those back to the boyfriend at their request. Not really a big deal in their view. Taking some citalopram for depression. Montreal cognitive assessment is 24. 26 is and higher is considered normal. In the general population, we generally expect people to perform a little bit better when they're more highly educated. So a little bit of a signal there on cognitive performance. Columbia suicide risk rating came back as low risk, and toxicology showed cannabis and ketamine in their system. So concerns based on the data available to you now. And this is the audience participation part of this. So just feel free to raise your hand or don't raise your hand, shout out what might be occurring to you. There's no wrong answers. Oh, I am so glad that you said that, because we're going to talk about, this is a very specific issue that we wanted to address, is the issue of acute intoxication versus carryover effects, and what do brains look like in a substance user who's not using. So, question here, but you're picking up on the cannabis and you're picking up on some cognitive difficulty, and there's absolutely no question in the literature that there's a relationship between cannabis use and cognition, both in acute setting, but also in chronic users when they're not acutely intoxicated. Who else has a concern? Say more. Right. Yeah, so some judgment problems here, some boundary issues. What else? Yeah, is that like part of the normal blood chemistry profile? I don't think so. So ketamine showing up in somebody's testing, what's that about? That wasn't reported. We don't have any data that I showed you that, but we do know that they have some depression. So go ahead, Lisa. Yeah, so there's a, that's a follow-up item for us for sure. Anything else? Say more. I'm so glad you brought up executive function, because we're going to spend some time on the prefrontal cortex in just a minute. But yes, so chaos. This looks chaos. this looks like a chaotic internal milieu cascading out into a chaotic external milieu in the practice environment. I would agree with that completely. So we asked some more questions. What about this ketamine? Reporting ketamine infusion therapy, but also the use of psilocybin, which is not something we typically test for, is difficult to detect without specialized testing, at a service center in Oregon. Some of you may know that Oregon now has psilocybin service centers and that whole story. This is a regulatory Wild West for you all. You might think that ketamine is mainstream treatment. There's still actually a fair amount of controversy about ketamine treatment, but particularly about how it's being promulgated in the community. There are some really good ketamine providers who do some good science. Ketamine is not approved FDA for any psychiatric condition, by the way. S-ketamine, which is an enantiomer of ketamine available by nasal inhalation, is approved by the FDA, but it's also part of a REMS program, so risk evaluation mitigation strategy. So it's very strict guidelines about how S-ketamine can be used in clinical settings. So there's a lot of basically off-label ketamine use. There's questions about the science of ketamine with regard to depression treatment. There was actually a study done just last year where people who were undergoing surgical anesthesia for surgical procedures who had depression were randomized to receive ketamine under surgical anesthesia versus placebo. So they didn't have any idea of whether they got the ketamine or not. Most ketamine studies can't be blinded. So they didn't have any idea, and guess what? No difference in treatment versus placebo groups in people who were blinded by surgical anesthesia in the randomization. So interesting. Still, the jury's out. I think as a regulator, you want to have a little bit of healthy skepticism when you hear about these ketamine cases, not be lured by the media attention and the hype, which is ahead of the science as far as ketamine goes. There are some good ketamine treatments out there. There are people who have definitely benefited from ketamine treatment, so I don't want to dismiss that either. But it's something that we have to keep an eye on. Psilocybin, even less science associated with the benefits of that, and lots of reasons to be very concerned about the use of psychedelics and other treatments which do have adverse effects despite the hype again. And so, we're learning a little bit more about this person, but also about how bad their depression is and how desperate people can be when they are trying to find a solution to an intractable mental health problem. And that's really what we're seeing here, is somebody who's really casting about trying to find a solution when typical treatments don't work. Guess what? The data on antidepressant treatment is not great either. So the stuff that's in my armamentarium, ketamine and psilocybin love a therapeutic vacuum. And what we have in psychiatry is a therapeutic vacuum. We have some treatments that work, but they don't work great. And people usually don't get the combinations of treatments that they need in order to be successful, which includes psychotherapy, frankly, which is harder and harder to get. But also a history of PTSD is revealed through this inquiry. And then revision of the cannabis story to, well, maybe I'm not just using it once in a while, maybe I'm using it more regularly, a few times a week. So at this point, in terms of next steps, what would you do? If you were us sitting around the table on a Tuesday morning with this data, having just finished our initial assessment, and this is exactly what we do. We kind of come together after we get to this point. We say, what should we do? Can this individual be evaluated by a local psychiatrist or addiction medicine specialist? Does this individual need to go for a comprehensive diagnostic evaluation, which is what CDE stands for? That's a multidisciplinary, multi-day test at a center that specializes in the evaluation of healthcare professionals. Or does this individual also need to stop practicing while we go about this additional evaluation, whatever that might be? So tell me first, how many people, by show of hands, think that this individual can go to their local psychiatrist or mental health provider down the street for further evaluation based on the data that you have now? How many people think a comprehensive diagnostic evaluation, a center specializing in healthcare professionals? How many people don't know? Okay, so everybody feels strongly, and I'm seeing a preference towards CDE. How many people think that this individual should stop practicing today pending further evaluation? How many people think that they could continue practicing while they wait for the results of the CDE to come back? Well, based on that weird show of hands where only a minority responded to either option, I think that there's some uncertainty, and that's good. We consider a cease practice recommendation a kind of high stakes recommendation to make. It's not easy to tell a health professional, by the way, you need to stop working today, but that is indeed what we do. And what's interesting about the work that we do and how it compares to the work that you do is you really don't have a good process to stop somebody from working quickly. We have a good process for being able to stop people from work pretty quickly because we don't have due process. So we tell somebody to stop working, and we tell them that we're going to have to also make a recommendation to your employer that you stop working pending further assessment. They typically stop working. If they don't stop working, then we call you, you do due process. But if we think somebody needs to cease practice in order to protect public safety, and we have a relatively low bar for that, but we also consider a lot of variables. An OBGYN in a critical access area who precipitously has to stop working could put patients at more risk than allowing them to continue to work under the current situation. We can't abandon care either. So we have to make some sometimes difficult judgment calls. Sometimes we reach out to you all at the commission and say, here's the situation. We're not telling you the name of the individual. What would you recommend that we do in this situation? How worried are you? Where does that land for you all? And get some consultation that way, right? So in this case, cease practice was recommended, as was a comprehensive diagnostic evaluation. Good job, everybody. Doing well so far. You're all hired. So we recommend the comprehensive diagnostic evaluation. We get diagnoses back. This is very helpful to us, right? We need diagnosis in order to act.
That he answers the HIPAA issue and then delinquency doing his charts, which is kind of an administrative, and then the drugs. So seizing of practice, what is your strong point? Is it the drugs were found? Is it the HIPAA? Where?
It's a combination. This case is that, and it's a great question. Thank you for picking up on it. Because there's no like smoking gun. There's no like near miss. Like our goal is to intervene in a way that protects patient safety when we don't know what's going on. What we know from this case is that it seems like there's a lot going on and a lot that we don't know about what's going on. We have evidence of cognitive impairment. We have evidence of use of substances that may be impairing their cognition, and we don't know at what level that really is a problem. We know that there was an initial story. We know that story has been revised. There may be further revisions that come with additional assessment. We know that there have been boundary pushes and some evidence of poor judgment already potentially affecting patient care. Again, we don't know what we don't know. So we know what we know, but we also know that there could be more to the story. So in this sort of case, given all of those kinds of pieces, we would probably err on the side of caution and recommend a cease practice. I give you that that's a judgment call, and on a different day, depending on a slightly different set of circumstances, we might be like, okay, we're going to let them continue to work while we sort this out. That makes sense? Just kind of additive, how many things are going on here. And this is a complex case. So significant severe major depression, co-occurring PTSD, and a mild cannabis use disorder is diagnosed as a result of this evaluation. So good, we have some reassurance that the substance use disorder is not worse, but there still is a mild substance use disorder. And then some significant psychiatric conditions that need attention and may be contributing to the overall picture here. So they get recommended for referral to psychiatry, for medication management, expert medication management. They get referred for counseling ongoing, and recommended for a 2-year health support agreement, aka monitoring, where we are going to monitor them. And we're going to do that. We're going to do an abstinence-based monitoring agreement with them, which is also recommended. So for a mild disorder, if they didn't have the co-occurring psychiatric conditions, we put them in a 1-year substance use disorder monitoring agreement that requires abstinence for a year, just to make sure that that substance use problem isn't progressing. It's also, you have to understand that these evaluations are somewhat limited by the fact that we can't put somebody in a scanner and say, where's the addiction? You know, we're always operating at a disadvantage in these cases because, one, rationalization denial associated with all mental health conditions, but particularly with substance use disorders. And we also have, physicians and healthcare professionals are highly motivated to evade detection of significant substance use problems or other stigmatized conditions. So we're always operating at a disadvantage because we're reliant on self-report. And we're often reliant also on the collateral reports of others, and then the way in which that data all coheres or doesn't cohere with itself in terms of deciding what we think might be really going on. Our toxicology testing paradigm today, which has been in constant flux since the pandemic, has been very difficult to support and maintain a robust toxicology testing system in light of the logistical challenges of testing, having collectors of the appropriate gender at the collection site, staffing problems with regard to collection site. Pre-pandemic, it was 48 random on-demand urine toxicology tests per year observed at the site. With the pandemic, we went to a self-collect model, and we've had a few iterations of that. Today, that's 50 tests a year, 20 oral fluid, 20 urine, and 10 whole blood phosphatidylethanol tests. And I can go into the details of that, but that's the overall. But in the interest of time, I won't. I would just say that it's robust and we think it's reliable, but we're still working out the kinks of all of that and how you do that. That's all self-collect. So people don't have to go to a lab. They can do it on through video monitoring. We don't video monitor people peeing in a cup. We recognize that those specimens can be substituted. It's very difficult, though, to substitute an oral fluid specimen in a video collection. So we mitigate against, we try to catch substitution if it's occurring through oral fluid testing, but we get a better window of detection and better detection parameters with urine, which continues to be the, all pun intended, gold standard toxicology testing. Phosphatidylethanol testing gives us a 2 to 3 look back for alcohol use. So on the initial assessment side, it can give we can semi-quantitate how much somebody's drinking and whether that measures to whether that coheres with their self-report of use, can invite a further dialogue. If their phosphatidylethanol is over 200 and they're telling us that they're a teetotaler, we know that that doesn't cohere. So we'll have to ask some more questions about what their alcohol use is really like and ask them and invite them to be a little bit more forthcoming about that. But at the same time, it could also confirm a self-reported history of alcohol use and give us reassurance that what they're telling us about their alcohol use is more akin to the true story. Again, and then in terms of monitoring or ongoing health support, a phosphatidylethanol test should essentially never be positive under monitoring. We do get some low-level positives that are a bit of a mystery still in terms of the science of this. So we follow those up with sometimes with additional toxicology testing, enhanced monitoring, even polygraph. And sometimes we never see a repeat and we never know what really caused it. There's limited data about incidental exposures that can cause positive phosphatidylethanol tests, but it continues to be a robust detection. And 70% of our detections are for alcohol metabolites. So alcohol continues to be the favorite drug of physicians in our sample. And like at 70% of our participants also identify alcohol as their primary and only substance of use. So we sort of double down on alcohol in terms of what we're testing for and make sure that we're robustly testing and detecting alcohol use, because that's what people are using in our programs when they are using under monitoring. We have workplace health status verification, a workplace liaison that reports to us quarterly. If they see any behavioral indicators of mental health, substance, or other issues, we provide them with training to do that and support to do that. We have health status verification from the psychiatrist therapist, for example, in this case. So quarterly reports coming in from them. Is the individual coming to their appointments? Are they following treatment recommendations? Is their illness in remission? If it's not in remission, do they have concerns about the individual's ability to safely practice? Bringing lots of data points, toxicology, health providers, workplace, so that we can provide advocacy, so that we can credibly say to those who wonder or need to know, is this individual safe to practice? And using all of these data points, we can make an assessment of that, provide reporting out and documentation of safety to practice as needed. We know that about a third of healthcare professionals just epidemiologically will have an impairing health condition in their career. So if you just look at the population and you look at how many people in the population are going to have mental health, substance use, or physical problem that could impair safe practice, or I should say non-psychiatric medical problem, it's about a third. That doesn't mean that all health professionals who have a condition, have depression, have an anxiety disorder, are going to be impaired. Illness and impairment are conceptually distinct, with impairment representing a functionally distinct domain of illness where the impairment related or the severity of the illness is such that it's beginning to affect ability to not only work and live, but also practice medicine, which is even a higher level of function. So we estimate expert consensus is about 1 to 2% per year are impaired. So let's talk about this idea about how the brain works. What makes us good doctors or PAs? What makes us different from chimpanzees, right? We have 98% our DNA is shared with chimpanzees, but that 2% is super important, right? And so what some of that 2% codes for is a much larger prefrontal cortex. So I would argue that the prefrontal cortex is super important for physician work. You mentioned executive function. That's where the prefrontal cortex lives. In our case example, we saw lots of evidence potentially of prefrontal cortex problems with memory, attention, concentration, psychomotor functioning. For our procedurists out there, planning and organization, do any of those things sound important to be able to do for a practicing physician? Yes. Is there wide agreement that those things are important? Do we also know, as physicians, that the prefrontal cortex is exquisitely sensitive to insult? Dr. Domino, is the prefrontal cortex susceptible to various types of insult? Thank you. Even my prefrontal cortex might have been insulted just by my lunch. But the point here is that, you know, we have this prefrontal cortex. It's really important for what we do. It's definitely affected by acute states of intoxication. So we're saying, okay, we have this individual, they're using substance. And I get this all the time, and this is why we're going to talk about this for a minute, because there's a myth out there. And the myth is I'm only affected by substances when I'm using them. I get doctors all the time who come in and say, but I've never been drunk at work. My substance use has never affected my ability to practice. And my first question to them is, how would you know? By what test are you able to make that assessment that your substance use has never affected your ability to practice? And then they don't have an answer, right? So the second thing I say is, wouldn't we want to intervene before the substance use has actually shown up at work? So I applaud that the substance use has not shown up at work, as far as you know, but by the time it does, you're in a whole different sort of trouble than the trouble you're in now. So let's be sensitive to your sensitive prefrontal cortex, and let's think about how the prefrontal cortex, particularly with regard to substance, but I would also say that we know that depression, anxiety, a variety of psychological and emotional states also negatively impact prefrontal cortex functioning in a way that I think can make practice at least impacted, if not unsafe. And so that's where we're living. It's like we want to make you safe to practice, and we want to get rid of things that are getting in the way of your prefrontal cortical functioning. So we know in substance conditions that there are both acute effects to the prefrontal cortex of intoxication, and these aren't the only brain areas that are affected. Hippocampus is certainly affected by chronic exposure to alcohol, memory, that's where memory lives. Carryover effects. So the effects of the substance in times of not acute intoxication, what are those carryover effects? And then hangover effects. Anybody have a guess as to the lost productivity costs of hangovers in the United States in a given year? About $150 billion a year in estimated cost for hangovers. Has any of us ever worked with a hangover? You don't have to raise your hand. But in a culture that highly condones excessive alcohol use, I would argue that a lot of people have probably worked with a hangover. We've certainly worked under other conditions of impairment, sleep deprivation, being ill from some medical problem. Like when I trained, you had to like be hemorrhaging or unable to control your secretions to call in sick. But if you had a mild fever, or you had a sniffle, or you had a cough, or you were at a URI, you were expected to work. Not to mention other things that might be impairing. And then as I said, it's not only substances, but non-substance related mental health conditions affecting the brain, the organ of impairment, the organ of medical practice, all affected. Just understanding a little bit about the neurobiology of addiction. There, as I said, it's not just the prefrontal cortex that's involved in addiction. We know this is a chronic, relapsing, remitting, often progressive condition. So hopefully we're catching it as at a stage where we can off-ramp some of that progressiveness, chronicity, and worsening course. But some people, not so much. They come, they do a monitoring program for 5 years, they go out and do some more research, and they come back because their illness is chronic and progressive. Sometimes they don't. And sometimes people can return to use. The natural history of substance use disorders is not that they are all universally progressive, as was the old teaching. Some people have a few crisis episodes in their life. They're able to self-moderate, and they don't need formal treatment in order to do that. But in the healthcare industry, when we're dealing with safety-sensitive workers, we don't have that kind of latitude. We don't give that kind of latitude to pilots, and we don't give that kind of latitude to law enforcement, FBI, nuclear power plant workers. So there's a whole range of safety-sensitive workers where society holds us to a different standard. So there, the newest kind of new neurobiology of addiction A lot of the old teaching about addiction was about the reinforcement pathways and the nucleus accumbens and ventral tegmental area. We now know that addiction is primarily driven by anticipation and wanting or craving. That seems to be the most prevalent driver of it. But it's also negative affect and withdrawal that we have downregulation of dopaminergic receptors with massive supraphysiologic doses of dopamine and substance that occur in a chronic user of substance. And that leads to an negative affective state, negative emotional state in the absence of substance that also drives the use of substance. The point here is that the brain is affected by addiction all the time, not just when the individual is using the substance. The brain is in a chronic state of chaos and dysfunction in somebody who's in active disease. So they don't need to be using at work, they don't need to be intoxicated, and their brain's still not going to be functioning well. Think about diabetes, right? Is somebody's diabetes only negatively impacting their health when their blood sugar is high? Or is the diabetes causing damage that is progressing in a repetitive way to multiple organ systems over time? Alcohol and drugs are just like that. But we also know that depression and anxiety states elevate cortisol levels, alter the HPA axis in ways that are also harmful to the human brain and the prefrontal cortex. So what do we know? There's some interesting data out there. It's not a huge data set, but I think it's provocative and telling. So there's Coker's study and Gallagher's study, both studies of surgeons who drank alcohol and then went into the surgical stimulator. So Coker's night out on the town, 5 surgeons, small data set, trained on a laparoscopic surgical stimulator, the MIST VR, which is the state-of-the-art laparoscopic surgical simulator out there at the time. A control night where they didn't drink and they had a full night's sleep, and then a sham night where they had nothing to drink and were sleep deprived, so just sleep deprivation, no alcohol, and then the night out, which is was going out and drinking alcohol ad litem, whatever you wanted to drink. And they measured the time taken to complete the tasks in the simulator, the error rate, and the economy of diastole, which is like electrocautery, and how well you're doing with that and whether you're burning too much tissue. And so guess what? Average ETOH consumption amongst the group was about 10 units. They didn't get blasted, but their blood alcohols were around 0.86% on average. So above the legal limit, but not wasted, not comatose. So good group of surgeons out having a good time, hopefully Ubering home. They had short sleep in the night out condition, about 3.75 hours. Morning after BALs were all 0. So they had no alcohol on board for the testing under the experimental condition. The sham only a 4 nights sleep, but no alcohol. Only affected time parameters in this study, whereas the affected time and total diathermy damage from electrocautery were both abnormal after a night of drinking the following morning. So Gallagher looked at this, decided to do another kind of follow-up study. In that study, they had 2 groups, 8 novices, non-surgeons, just yahoos like me that went in and fiddled around on the surgical stimulator, on the simulator, and then they had 8 expert laparoscopic surgeons. And so they wanted to have this kind of control group of non-experts to just see what was the effect of alcohol on people who aren't surgeons, and then what's the effect of alcohol on the surgeons. All subjects were alcohol experienced and instructed to drink freely. They weren't teetotalers, they weren't novices to alcohol, beginning at a restaurant dinner, simulating real life circumstances, and home by midnight. So all reported a good night's sleep, testing the next day at 9 a.m., 1 p.m., and 4 p.m. in the afternoon on surgical simulator performance. The novices ingested about 16.5 units of alcohol. Experts' ingestion was not measured, but intoxication was confirmed by direct observation of the researchers at the night out event. And one of the 8 subjects had a positive BAL at the morning test. So still alcohol on board at the time of morning surgery the next day. In the intervention group, the control, all performance measures at baseline. The control group had no changes at baseline and through the 3 testing sessions, but large differences in performance versus the alcohol group, with the alcohol group performing worse on all measures. That's the novice group. And then in the expert group, with the exception of time taken at 9 a.m., all other measures, time, error rate, and economy of diathermy was worse from baseline at all 3 time points, 9 a.m., 1 p.m., 4 p.m. the next day. The upshot is that if you're drunk the day before surgery, your performance is going to be impacted until 4 p.m. the following day. Is that surprising to anyone? Do we tend to assume maybe that we can put powerful brain-altering substances in our body and not experience adverse effects of it in terms of our performance? So this was an editorial provided by some other surgeons who read this study, citing, because I'm not a surgeon, so I kind of wanted to see what other people thought of this study. The effect size, the magnitude of the measured effect was substantial. This was the best simulator that money can buy for measuring this sort of thing. The effects of alcohol on surgical performance were apparent after biochemical recovery, meaning that there were significant carryover effects. The brain was negatively impacted, and that this means that we really do have to think about this as a profession in terms of how we train our medical students, how we train our residents to think about how their use of substance impacts ability to perform. Cannabis is now legal. We don't have good cannabis studies in physicians, but we know that cannabis use among physicians is increasing as it's normalizing in the general population. This is a old, pretty often cited study actually from 1985 of the pilot study. So this is pilots, 10 pilots, pilot licenses, experienced pilots. They smoke a 19 milligram joint the day before going in the simulator. I don't even think you can find a 19 milligram joint anymore. Like, this is the old school pot that I grew up with, but the pot that's out there now in the 20 to 30% THC range for flower, that's a 30 to 50 to 75 milligram joint. So the dose that people are getting today is much stronger. But even in this study, all of the pilots performed poorly the following day after smoking marijuana. They weren't intoxicated. This was a carryover effect. They were measured in the simulator before they smoked the marijuana and did just fine. But off-center landing deviations that can easily result in crashes were predominant in this group. So these weren't just mild or moderate deviations. These were crash-worthy deviations in simulator performance. So really, I think adding a little bit more to the data that we have about the carryover effects of substance. And certainly in large meta-analyses of cognitive effects of cannabis in chronic users, the data is clear. It's uncontroversial that chronic cannabis use negatively impacts cognitive function, whether or not intoxicated or not. Whether that cognitive function can return with abstinence is a more open question. We've seen lots of physicians and PAs improve in cognitive performance with abstinence, so I believe that it actually can normalize. In Coker's paper, he says most humans underestimate their risk liability and incorrectly assume that experience will negate the ill effects of risk behavior, including alcohol, sleep deprivation, and hangover. And I do think that one of the dirty secrets we have in medicine is the negative impact on performance of sleep deprivation, which we tolerate, and in fact encourage a mentality that we are somehow immune to an unhackable reality of cognitive performance. You cannot deprive sleep and not have decrement in cognitive performance. That's not controversial either. Yet we act as though we somehow are immune to the effects of cognition in our performance. So our model is a voluntary, confidential, therapeutic model to help those who might be suffering from these conditions that can negatively impact cognition and therefore practice, and therefore the safety of the patients that they serve. The model is accountability. Accountability leads to safety. Safety leads to earned advocacy. And most of the people who are coming to our program need an advocacy and credibility prosthesis because of things that have happened as a result of their substance use or their mental health problems or other issues. And then, of course, we make a notification to the regulator when indicated, and they'll talk a little bit more about that. And with Mike Farrell's help, we were able to do an analysis that I've been wanting to do for a number of years on outcomes of cases for WPHP referred to you all. Because I think knowing, we're always wondering, is the porridge too hot, too cold, or just right? Are we referring individuals to you that you actually want to be involved with and see because you too share our concern? Are we sending people that you have no concerns about and you're wondering why in the hell this person ever ended up in front of you in the first place? Or are we getting it just about right? And I'm going to ask you to consider that as we move forward here in just a moment. But this is our model. An individual gets assigned to a case manager when they get referred to WPHP, and that case manager shepherds them through the process from beginning to end, whether that's at the end of a 5-year health support monitoring agreement, or whether they're off-ramping after the initial assessment or off-ramping after the independent evaluation. Those off-ramps are about half of people that get referred. So only about half of people that get referred to us really require ongoing health support monitoring. And I think that's good. I think that's right. I think that's as it should be. We want to provide help and service upstream of impairment. We can often get people directed to those resources, and they need them. I mean, people aren't getting referred to us for nothing. There's usually a reason why they're getting referred to us, and there's often unmet need that we can meet. But not everybody needs to be in a long-term monitoring agreement with WPHP. I think another thing that you often hear about when you meet with individuals or you hear complaints about WPHP is the cost. And we certainly recognize that cost is a significant burden. I'm advocating nationally on ways to help alleviate those costs and reduce those burdens to individuals, and that's a slow path. In the meantime, we try to provide some shore up assistance. We gave almost $200,000 in assistance to individuals coming to WPHP who on a need basis. We did need-based grants, $3,000 for evaluation, treatment, whether that's inpatient, outpatient, residential, their initial evaluation to get to a diagnosis and answer. And people are ineligible for those grants up to 3 times. So we'll give an individual up to $9,000 to help move them through the program. So we're doing what we can. We also do fee deferral and payment. We're not trying to get rich with this. We understand that people coming in may be in one financial circumstance that may improve. And that's typically the trajectory towards both health and financial improvement over time in the program. So we can defer, we can let them pay later and defer those costs to later when we can to help people get through it. We're also in a pilot program with the University of Washington. So students, PA students, as well as medical students, residents, in the program, none of those folks have to pay for their evaluation. If they're recommended for one of these fancy doctor evaluations out of state, WPHP covers that cost through our contract with the University of Washington. I mean, they pay essentially, but we manage the risk. We are way over what they paid us. So we're actually doing most of the paying at this point. We'll have to renegotiate that because guess what? When you pay, people come. When you lower that barrier, all of a sudden the referrals are coming and the evaluations that need to get done are getting done. Now, GME and School of Medicine accounts for probably about 37% of our referrals. So we're getting to people earlier in the career trajectory, which to me feels like a win, right? So a lot of good work that we're doing in this area. When you hear people think that we're not sensitive to the financial issues, it's part of our daily fare. And we're doing everything that we can within our program to meet their financial need and also find resources outside of the program so that they can get done what they need to get done. For those of you who are on our panel discussion this morning with the individual who had been imprisoned for several years and you heard about that individual's financial circumstances, yet able to work with us and find a path forward, it gives you a perspective with some of the people who also complain about their inability to work with us because of financial, and whether that's real or something that they're imagining or using as a reason for not wanting to work with us. So people who are pretty destitute can still successfully get through our program, get our endorsement to practice and find their way back. Just depends on where there's a will, there's usually a way. We have a reconsideration process. So people say, well, WPHP just decides what they want us to do and we don't have any say about it. First of all, we have a really robust informed consent process. It is a script. We walk people through in a very detailed manner. What are the risks and benefits and alternatives of participating in this program? And do you even want to work with us, given what we can or can't do for you? And we actually stop at the end of that process and we say, do you wish to proceed? We don't want people divulging a bunch of protected, sensitive health information to us if they don't want to proceed with us or they have reservations. Sometimes people say, yeah, time out. I want to talk to an attorney. I want to talk to a family or friend. I want to get my head around what this process is about and what you all do before I want to move forward. We give people space to do that. Most typically, they come back and work with us after that. But we do have, I think, a very detailed. So people can't say we didn't explain the process. I didn't know what I was getting into. Like, we actually have it documented that they knew what they were getting into and that we asked them if they wanted to proceed and they said yes. That's our process. But we do make some high stakes recommendations, like cease practice, like go for an expensive out-of-state evaluation. Oh, that evaluation said that you need 90 days of residential treatment, so we're going to hold you to that. And they disagree with the recommendation. So we have a process that's written out, that's provided to them at the front end. Again, patient participant rights, responsibilities, and reconsideration is the name of the document that we hand them, so that they have that, so that they know. If you disagree with something that we say, here's the process, here's how it works. First thing we ask is, was the recommendation already vetted through clinical staffing? So all of our high stakes evaluation is a clinical consensus team process. We don't have some yahoo that works there that's going, you know, off on their own, making some, you're going to stop practicing and you're going to do this and you're going to, we don't do it. That all gets done with me and Dr. Moss and our clinical director, Courtney Strong. We're all sitting in the room on Tuesdays and Thursdays, and we're reviewing these cases and we're making clinical consensus decisions, taking into account all of the various factors, because we recognize that these are important decisions and they need a clinical consensus process. Is there a substantive new data or inaccurate information? So we ask for in reconsideration. Is something new? Is there some new piece of data? Was there a piece of data that you think wasn't properly considered or weighed in this process? Has something changed? Is there something inaccurate in what we've told you about how we've conceptualized your case? That stuff can be brought forward at that point in time, and then I make a decision as to whether this qualifies for reconsideration. There's not, everything doesn't qualify for reconsideration. You can imagine we could be bogged down in infinite reconsideration as a delay tactic. So we have to make some decisions about what will be reconsidered, but we try to be fair. If it's going to be reconsidered, we send it back to the clinical team for that same consensus process to reconsider with some notes from me as to what we might want to reconsider or weigh differently. And the process, I think, is meaningful. I haven't done a systematic review, but I can say anecdotally that it feels to me that probably in 2/3 of the cases, there's a modification, adjustment to the recommendation to meet the participants' concern in a way that they ultimately find is satisfactory, and we can move forward at that point. So I like the process, and I think it works well. If you don't think that we are completely rigid and inflexible, although sometimes we characterize us that way. In terms of evaluation and treatment, how we select our evaluation and treatment providers, we have a Department of Health contract that requires that individuals that we work with use a pre-approved evaluators, approved evaluators. We can approve some new evaluators on the fly depending on what the circumstances are, but the point of this is that no expert body, whether it's the Federation of State Medical Boards, the Federation of State Physician Health Programs, ASAM, would endorse the idea that individuals should just be able to choose their own evaluator. When you choose the evaluator, that evaluator works for you, and you get the answer that that individual wants. That evaluator should be independent, objective, and qualified. And there are guidelines through the Federation of State Physician Health Programs, Federation of State Medical Boards, even delineated to some extent in our DOH contract, that describe the qualifications and criteria for these evaluators, describe the qualifications and criteria for treatment providers. So we're following a recipe in terms of determining who can really do this work and do it well and understands what's involved in safety-sensitive work. Most cases are resolved with health and reinsurance. As I said, we assessed 84% of referrals last year. They often require health support and advocacy. Unknown fact, I mean, I think we're often thought of as a substance use disorder treatment program. I spent a lot of time talking about substance use disorders, but actually 2/3 of our referrals are for non-substance related concerns. Some of those convert because sometimes problematic workplace behavior, sometimes performance issues that aren't recognized as being substance related become substance related on further analysis. But people coming through the door for lots of different things compared to inception 30, 40 years ago when most all we got was substance use disorders. Program participation has been declining over time. Referrals have been declining over time. There are lots of reasons I think that that's happening, although this year is the turnaround year. We are on pace to have more referrals by far than we had in 2019 this year, which is not well timed considering we've been understaffed since the pandemic. So we have more referrals than ever. They are more complicated than ever, and we are least well staffed for them than ever. So I give a lot of kudos and support to my team for hanging in there with us. Referral reasons, as I said, about a third are psychiatric. About 20% are problematic workplace behavior, and we call it problematic workplace behavior because we don't know what the problem is. We don't know if it's the workplace or the doc, and sometimes it's both. But we try to remain agnostic, but we understand that there's some type of conflict occurring that's getting that individual referred to us. Medical, non-psychiatric conditions, and then substance use disorders, a robust third as well, coming to us. Are these safe professionals? We think so. We think that a health support agreement that is robust, that encourages treatment adherence, that manages risk of impairment should illness recur in an observed state, in an ongoing monitored state, the way that I mentioned, that you have reassurance of somebody who's in our program versus the universe of unmonitored, unwatched professionals out there. We know that professional liability risk goes down as somebody enters the program and then is lower than the universe of non-PHP participants at program graduation, at least in one fairly robust study out of the Colorado Physicians Health Program using the COPIC Professional Liability Insurance Database. We also did that analysis years ago because physicians at WPHP were being surcharged by Physicians Insurance. They were known to be in the program, but we went to Mary Lou Mizrahi. We said, Mary Lou, who is the new CEO at Physicians Insurance, we think that our docs might be safer than the rest of the docs that you're underwriting. She said, I'll take that bet. And she did the analysis, and she actually found out that our docs were safer than the general population of physicians from a claims perspective. She eliminated the surcharge, and then she served on our board of directors for 12 years. So she became a true believer from the professional liability standpoint that doctors in our programs were safer and that our programs should be supported. We report to you, there's different statutory language present in different statutes around this. One level is clear and present danger, but really I think the bar is lower, especially in 18-130-175 that describes, reasonable concern for impairment, substantive non-adherence with a support agreement. That's somebody who we just can't get into compliance and we're going to discharge from the program. And usually we report to somebody to you when we're either resolving their case, that's pre-monitoring, when we're saying we're resolving your case for non-compliance. You're not following program recommendations, you're going to get referred to your regulator. We had 29 health support agreement participants under order by their regulator. The breakdown is there for your entertainment. We had 6 reports to the regulator in 2023. That was actually a pretty low year. We like it when we have a year where we don't have to send many folks your way. And of those, 2 were to the medical commission. But as you can see, and you think about the difference in licensees and participants in our program, 2 to WMC is pretty low compared to 2 for DQAC and 2 for, which is a much larger percentage, obviously, of the overall pool. Who gets reported? 2.5% of cases in development last year, 0.96% of participants under agreement. These individuals are literally 2 standard deviations from the mean of our experience. That should tell you something. Somebody's getting referred to you because we can't work with them. It is not for lack of trying. We have tried to find a path forward with this individual. It is not working out either because they can't or won't work with us. And I say that because I think you guys do a really good job of responding to the signal that is a report of concern from us. But not all of the regulator entities that we work with see that signal the same way. But it is important, and I think that you should know that you always have access to our records for somebody that we notify you on. Review of those records can really illuminate the case for you. So if you've got a WPHP notification and you haven't seen the records, you should ask why, because we should have gotten those records to you. This is what Mike helped us out with in terms of looking at the outcomes of regulatory cases that we were involved with over 5 years. There were 34 referrals from 2019 to 2023 from WPHP to the regulator for those reasons that I just showed you. And then these were the outcomes. So 3 were still open. The final outcomes were that 14 were closed, 2 were put on conditions, 7 were actually surrenders, and 8 resulted in suspension. So, what's the ideal? We don't know, right? But what I think, what you can ponder on and talk about later is, I think if the porridge is just right, that, there should be a good mix of outcomes with the cases, right? There should be, not every case that we send you, it shouldn't be a fait accompli that there's going to be some sort of action. You have to do your own process. You look at this through a different lens, and you have due process requirements that require you to handle these cases in a way that we can't predetermine what the outcome is, and we shouldn't be able to predetermine what the outcome is. But we should have some pretty good guesses about what the outcome will be. If I get a call about a doctor and that doctor doesn't want to play with me, I have to ask myself the question before I even call that doctor, if this individual says that they don't want to play with me, because can you imagine? Hi, this is Dr. Bundy from the Washington Physicians Health Program. You don't know me. You haven't heard, but I'd like you to come in and answer all my questions and do all this testing. And they say, thank you, but no, thank you, Dr. Bundy. I prefer not to do that. So I have to know at that point whether I actually am going to have a requirement to notify you all if they don't decide to play. What's the evidence I have? And that requires me to make an educated guess about what I think you might want to know about. And if I can't make that educated guess, I might call. I might talk to Micah, or I might talk to Kyle, or I might talk to Rick, and I might say, what do you think? You think your commission would be interested in a case like this if they don't want to play ball with me? And they can give me some signal about that as well. But I think that's how we try to get to the right answer. But the devil's in the details here a little bit, because let's drill down on the closures, right? It's kind of interesting. 14 closures sounds like, wow, that's a lot of cases that weren't interesting to us. But they actually were. They just had an outcome that you didn't have to deal with. So a couple of those people died. Several of those people decided that they were going to retire, and you said, okay, we'll let you retire if you try to re-enter practice, and we'll deal with it that way. A couple said, you know what, I'll just go do what WPHP wanted me to do after all. You said, good, so we'll close it that way. So they ended up back with us. But if you take into consideration like kind of all comers and what ended up happening, it's about 83%. I think really the 4 that were cleared with no action, it's about 83% had some action or otherwise were no longer practicing. So I think that's also a pretty good number. We want kind of a nice majority of people who we're sending for our worry or concerns. It kind of lines up to the worry or concern that you have, but it also leaves room for people to also, for you to not act, right? You're also not acting in cases where you really don't think that there's enough there. And we want some of those too, I think, in order to feel like we're doing this right. Now, I realize that we're going over and we're getting into your case time, so I'm going to go really fast here. I think our program data and outcomes speak for themselves. This is all in your DOH report and packet as well. We have not had a suicide in our program in the last 2 years, but that could happen at any time. We've had 5 program suicides in 12 years. We do a lot to mitigate suicide risk, and when we have a program suicide, all of those go out for external peer review by experts in physician suicide to help us look at if there was anything, did anything drop below standard of care for physician health programs? Is there anything that we can do better? We have the highest rates of substance abstinence by the most robust measures available to test for it in all of addiction medicine. So these are data that we can be proud of. If you're a housed employed individual in the general population, you're going to be 50% relapse in 6 months in usual care. So the fact that we have 12-month abstinence at 92% and 60-month abstinence at 87%, I think speaks to both the contingency management, accountability, but also the chronic illness management model. That's really where we're winning. In terms of survey highlights, we have less than half the rate of burnout in our program. Interesting, right? Because you would suspect that sort of out of the gate, people who have more mental health and substance use problems might have more problems with burnout, but the benefits of program participation do extend beyond the impairing health condition. These are individuals who are grateful, happy to be in their practices, and using adaptive coping strategies that they've learned in and out of the program to better deal with the strains of practice and increase their resilience. A large proportion of individuals who are benefiting and needing from the advocacy that we provide for them in employment, credentialing, licensing scenarios. High rates of self-reported remission. That 1%, that one participant actually wrote in the comments of like, I'm in full remission, but I have a substance use disorder, so I'll never actually fully cured of my disease. That's not the right answer, but I'm not going to change their response. So otherwise, we'd have a 0 in the no response column. High ratings, I think, for service from our stakeholders. So those were participant satisfaction variables. We also measure you all. We send surveys out to you. We send surveys out to our treatment providers, our evaluators, our stakeholders in the community, ask them how we're doing. Those who have made a referral in the past year get asked how we're doing, and results. We have a lot of challenges and highlights and things that we're working on. Staffing and turnover, I mentioned. Stabilizing our toxicology testing system remains an ongoing issue. But I still think we can credibly back our toxicology testing with what we're doing today. It's just taking a lot more effort than it needs to. We're working on the front lines of credentialing reform. I'll be at the underwriters workshop for the National Professional Liability Carriers in a couple of weeks, talking about reforming their credentialing questions. Physicians Insurance just reformed their credentialing question. I'm working with the University of Washington to reform their credentialing question. I went to the Washington Association of Medical Staff Specialists this year to talk about their credentialing questions, Ms. Blake. So, you know, this is a hot topic nationally about licensing and credentialing, being in violation of ADA, asking discriminatory questions, and prompting probing inquiries about mental health and other discriminatory practices. So we have to be mindful of that, and there's some institutional risk that's becoming apparent as some senators wrote to the DOJ last year and asked the DOJ to look at credentialing and licensing practices as an ADA violation, what's okay to ask and what's not okay to ask. You guys did this back in 2017. Prior to Lorna Breen, prior to all of that interest, you were way ahead of the curve. I was, again, thinking about the collaboration. I was invited to work with the policy committee to reform those questions based on emerging best practice at the time. And you all were leaders in credentialing reform and ultimately moved to an attestation model. The DOH, the rest of the licensee groups in DOH still have to catch up. But they're working on it. And you, again, were the leaders in DOH and as well as nationally. Lots of quality assurance work, working on our communications program to better educate the community about what we do. We provide a lot of hours of education in the community. We have a ton of additional resources. Please visit our website if you want to see what those are. We just did a refresh on that. And so we have a lot of, I think, good information. I could stand here and talk to you all day and show you data, but really it's these program testimonials and success stories also available on our website. We have a landing page video of a WPHP participant describing publicly and within their organization at Providence what their experience was like. A very courageous, self-disclosing view of WPHP. I'm always available to you. Your staff knows how to get a hold of us if you have questions about a particular case. It was not unusual that not too long ago that if a reviewing commission member had a question about a case involving WPHP or even a case that they thought might need WPHP involvement, that either the staff attorney or the investigator working with that commission member would facilitate a discussion with us. Courtney Strong, our clinical director, just know that we're available for that. We want to work with you, partner with you, and provide you with the information to feel like you can do your jobs well and sleep better at night, have it for the experience. We are here to serve. The license holders who benefit from our services fund 80% of our operating budget, and we really see ourselves as needing to be a resource across the healthcare continuum in Washington. Thank you for letting me go over my time a little bit and for allowing me to start just a little bit late. And I'll be happy to hang out a little longer today and answer any questions. I wish we had more time now, but I also want to recognize and respect the fact that you have other things to do. So thank you.